Good evening to everyone and welcome to today's session. So we still have around 90 days before the NEET PG in the third week of March. A lot of time, and still now we can rise, start walking and start running and finish most of the high-yield topics and still become a winner. Another rekindled hope because of this postponement. So I decided that every day I'm going to spend with you all and at least 1 to 2 hours of my time, and we will try to do a revision. There is a schedule for our session until March 3rd week. Additionally, you also get 427 hours of high-density video lectures covering all 19 subjects, 10,000 PowerPoint slides, and around 10,000 MCQs, which are very high yield in the form of quiz tournaments on the Incus app, and also around 10,000 PowerPoint slides of notes for a unbeatable offer of 10,000 rupees in this next 3 months. So I hope in this journey you will be able to crush through most of the high yield areas and then recharge and energize your preparation. So let's make the great beginning, Doctor. So yes, I hope you all have answered the 50 questions which have run like a PowerPoint slideshow for all of you. Good to see Venkatesh, Pranav, Madhavi, and many more who are all online. Can the online students punch whether the voice is loud and clear, Doctor? Please punch whether the voice is loud and clear. Yes. So every day evening, 6 o'clock, without a failure, you have Dr. Murali Bharadwaz available for studying along with you all guys. Yes. Now, Doctor, Pediatrics, there are about 600 questions in Pediatrics. By the time we do the revision of the 600 questions in the next 6 days, you will get almost all the concepts completely into your grip. And on the top of it, whenever you are still feeling a bit shaky, you can go back to the onlinembbs.com video library and can do the revision. Now, unconjugated hyperbilirubinemia in the neonate is seen in which conditions? Online students, please punch whether the voice is loud and clear for all of you. Yes. In the neonate. So you should remember that the Dubin-Johnson is a conjugated hyperbilirubinemia. So you should know what are the fundamental differences. Krieglinase is the deficiency of glucuronide transferase. Dubin-Johnson is a decreased hepatic excretion of the bilirubin, and Rotor syndrome is considered to be a secretory defect in bilirubin. So it is also autosomal recessive. Only difference between Dubin-Johnson and the Rotor is there is a pigmentation, deep pigmentation of the liver because of the melanin in case of the Dubin-Johnson. So Dubin-Johnson may, what do you get, Doctor? Dubin-Johnson may piggy liver. You get piggy liver because of the melanin. Then one more important feature about the Dubin-Johnson is coproporphyrin 1 to coproporphyrin 3 ratio is increased. And also there is a bilirubinuria because Dubin-Johnson is a conjugated hyperbilirubin. And often Dubin-Johnson's hyperbilirubinemia is a mild hyperbilirubinemia and it is a fluctuant hyperbilirubinemia. So these are the points you need to know. And most often these patients of Dubin-Johnson will spend a normal lifespan is what you should remember. Kriegler-Nasser is type 1, type 2. Type 2 is more milder because it is autosomal dominant. It is a partial defect on the glucuronide transferase, whereas the type 1 is autosomal recessive, where there's a complete absence of the conjugating enzyme is what you need to remember. So broadly, if you take the jaundice, unconjugated, conjugated and mixed. So whenever there is any hepatic dysfunction, then typically it is mixed. Unconjugated can be pathological, physiological. Pathological is hemolytic jaundice. Physiological, pathological can be hemolytic, non-hemolytic or congenital. So congenital is Kriegler-Nasser and Gilbert. Both of them are unconjugated pathological hyperbilirubinemias is what you need to remember. Conjugated bilirubinemias can be post-hepatic causes or congenital. So Dubin-Johnson, rotor. Only difference is rotor may liver pigmentation nahi hota hai. There is no pigmentation. Whereas Dubin-Johnson has a pigmentation of the liver is what you have to emphatically remember. A 7-day-old infant develops symptoms of neonatal septicemia. What is the most common cause? It is the local nursery environment, which is responsible for the transmission of the organisms that lead to the development of the neonatal septicemia is what you should remember. Neonatal necrotizing enterocolitis. So typically those preterm babies who are suffering hypoxemic injury typically have neonatal necrotizing enterocolitis. So it has abdominal distension as a presenting feature. Abdominal distension. Then metabolic acidosis, pneumoperitoneum, because the moment the gut is having any necrotic process that can lead to development of a perforation leading to the entry of the air into the surrounding peritoneum. So pneumoperitoneum. Decreased bowel sounds will be there, not increased bowel sounds. So that is a neonatal necrotizing enterocolitis. Now, what are the physiological signs and physical signs of necrotizing enterocolitis? There will be temperature instability, apnea, bradycardia, desaturation, lethargy, acidosis, and thrombocytopenia. Physically, feeding intolerance, increased gastric residual, abdominal distension, occult blood, hematochezia, peritonitis, discoloration of the abdominal wall, and sometimes abdominal mass can be the physical signs of necrotizing enterocolitis. Exclusive breastfeeding. It should be given at least until when? At least hota hai 4 months. 4 months is the golden number. What are the problems with exclusive breastfeeding? Evening coli, golden colored stool, prolongation of physiological jaundice. Anything can happen with exclusive breastfeeding. Hemolysis because of the vitamin K deficiency, golden color stool, anything can happen, but not evening coli. Yeah. peak growth velocity. Generally, girls grow faster than boys, right? So all that growth happens before commencement of menarche. Typically in 6th class, 7th class, the girl on whom you have crushed become taller than you. You feel diffident, oh my God, how can I propose to this taller girl? But in 8th class, when your classmate entered menarche or 7th class, after that, you start growing faster, taller than her. So that's a difference. So you should remember the timing of puberty, a very, very important point you need to remember. So there's a difference between boys and girls. The pubertal growth spurt, it occurs on average nearly 2 years earlier in girls than boys. The sex hormones are produced in adrenals by 6 years, which is called adrenarche. And they are most prominent in girls due to general adrenal component, greater amount of adrenal. Girls have a greater adrenal component. Now, the growth in the post-menarchal period is limited as girls can gain 5 to 6 centimeters in linear growth only. That is the reason the maximum gain in the height typically happens in the pre-menarche period. Klinefelter में क्या होता है भैया? Long stature, not short. They'll have subnormal intelligence. So boys with mental retardation, psychosocial learning, or social adjustment problems, you should think of Klinefelter. Pneumatocele, typically, where do you see pneumatocele? Typically, pneumatoceles are caused by the staphylococcus, as what you can see here. There is a pneumatocele, and this is caused by typically the staphylococcus. What is the most common cause of the portal hypertension in case of children? It is the extrahepatic compression, which is mainly responsible. So, but before that, you should know what is the definition of portal hypertension. The normal portal venous pressure is 5 to 10 millimeters mercury above the pressure present in the IVC. And portal hypertension typically is defined as an elevation of this gradient to almost 10 to 12 millimeters of mercury. So what leads to portal hypertension, doctor? Any intrinsic liver disease or liver fibrosis. It can be pre-hepatic, post-hepatic, or it can be because of a very high blood flow. So extrahepatic portal vein thrombosis, cavernous transformation of portal vein, or any extrinsic compression of the portal vein. So that is the most common cause of the portal hypertension. So the pre-hepatic causes is the most common. Out of the extrinsic compression, extrahepatic extrinsic compression of the portal vein is most common cause. So post-hepatic में होता है Vardhathey syndrome. You know, you have the liver, doctor, and this is the gut. So mesenteric vein and the splenic vein. So they combine to form the portal vein, and portal vein goes to the liver. And from the liver, it comes out as the hepatic vein. Hepatic vein drains into the IVC. I think you all know this journey. Mesenteric vein and splenic vein combine to form portal vein. Portal vein go to the liver. In the liver, all the venous radicals combine and they come out in the form of hepatic vein that drains into the IVC. So whenever any problem occurs before liver, you call pre-hepatic, like portal vein thrombosis or Vardhathey syndrome. And any problem that occurs after it leaves the liver and journeying towards the IVC, that is the hepatic vein, you call post-hepatic. Between prehepatic, posthepatic, prehepatic is more common cause, and the portal vein extrinsic compression is the most common cause, is what you should remember. So, portal vein thrombosis is more common in pediatric population, and the normal liver function is what you see, and encephalopathy-like complications are less common with portal vein thrombosis. Ultrasound, CT, MRI can help you, and quite often the portal vein thrombosis presents with variceal bleeding in a non-cirrhotic patient with a normal liver function who presents with variceal bleeding. You should think one diagnosis, that is portal vein thrombosis, is what I want to underscore to all of you. Once more I want to tell you, cirrhosis nahi hai, liver function test normal hai, फिर भी Chotu is having a variceal bleeding. That should make you to think of the possibility of portal vein thrombosis, is what I want to underscore to all of you. Atrial septal defect. So typically in atrial septal defect, the left atrial blood is passing through the ASD into the right atrium. And all that right atrial blood will pass through the right ventricle into pulmonary artery. And all that pulmonary artery flow is increased. And because of that increase, you get a left parasternal heave in case of the ASD, is what you want to underscore to all of you. Otherwise, in ASD, second heart sound is wide and fixed. And across the shunt, the blood flow that happens does not produce any systolic murmur. Because VSD-like situation, there is a huge pressure difference between left and right. Whereas in the case of the ASD, the pressure difference is not that much to lead to the development of the systolic murmur, is what I want to underscore to all of you. Rib notching of 4th to 9th ribs, typically along the inferior border of the rib. Rib notching is the feature which you see in case of the coarctation of the aorta. Then, what is the marker of renal vasculitis in children? Whenever there is any IgA nephropathy, it can lead to renal vasculitis. IgA nephropathy is also called IgA vasculitis, called Henoch-Conlin's purpura. So basically, there are two ends of spectrum, doctor. Please remember that if you look at IgA nephropathy on one side and HS purpura on other side, they both are two ends of spectrum. IgA nephropathy is involving predominantly kidneys. In HS purpura, you find a lot of skin lesions. It is also called anaphylactoid purpura. So IgA vasculitis is the one which is responsible. So now quickly summarize and tell me about HS purpura. If I ask you a question, most common systemic vasculitis in pediatric population, what is your answer, doctor? Most common IgA vasculitis. There is a palpable purpurae, arthralgias, GI involvement, renal involvement, elevated serum IgA levels. They are all the classical features. And in the small vessels, you can see the deposition of the IgA immune deposits, mainly in the capillaries, venules, and arterioles. So that is what is the 5 to 6 points you should remember about Henoch-Conlin's purpura. So there is inflammation of the glomerular capillaries, IgA deposits in the glomerulus, inflammation of the skin vessels in the skin, small vessels in the skin, and IgA deposits of the small wells in the skin viewed with immunofluorescence microscopy. So this is what you should remember. Systemic juvenile arthritis, what do you know about it? It can lead to triad of clinical features. What is the triad, doctor? Fever, splenomegaly, then there can be leukocytosis, but negative rheumatoid factor. That's what you should remember. So basically, juvenile rheumatoid arthritis is being divided into 3 types: pauci-articular, polyarticular, systemic onset. Pauci is more common in the girls than boys. ANA is positive. Chronic uveitis is 3 times more common in those who have ANA negative compared to that of ANA positive. Then polyarticular, if the RF is positive, then it has a worse prognosis. Systemic onset, both ANA and also RF, they both are negative. So generally in juvenile rheumatoid arthritis of systemic onset, the chronic disease is unusual. So these are some of the funda that you need to be very sure about. A child is having alopecia, hyperpigmentation, psoriatic dermatitis in the genitals and the mouth, acrodermatitis enteropathica, and hypogonadism. So typically is a feature which you see in zinc deficiency. Phocomelia is absence of long bones is phocomelia. Neuroblastoma, what is most common presentation? It is these lytic lesions in the skull, and the sutural diastasis is considered to be the most common presentation. What is the most common cause of the pyogenic meningitis in 6 months to 2 years of age? It is the H influenza. So based upon the age group, you should know what is the most common organism. The most common cause of the hydrocephalus in the children is the post-inflammatory obstruction that lead to hydrocephalus. Now, increased acetylcholine esterase in the amniotic fluid. Where do you see? Keep punching your answers, doctor, so that you're all active. So I want to tell all of you, अभी हमारे पास 90 days बाकी है. We still have 90 wonderful days before the NEET PG exam. The time that you accumulate energy, forget about the past, think that this is the God-given opportunity to once more arise, awake, and stop not until you win. Right? So, every day 6 p.m., please tune to youtube.com/onlineMBBS. And you have Dr. Murali Bharadwaz. And also please remember, before we start this discussion, I will give this like a quiz of a PowerPoint slideshow. So sit along with your friends and keep punching your answer. Every 12 seconds, one question keep changing. Keep punching your answers. Then Dr. Murali Bharadwaz will come and take up for a discussion. In addition to that, I want to tell all of you, please join and subscribe to our crash course. So what do we offer in crash course? We offer all of you 150 hours of daily live class covering all the 19 subjects between December 13th to March 14th. Number one. Number two, 427 hours of HD video containing 1500 video lectures on the onlinembbs.com video library. Number three, 10,000 MCQs that you can play like quiz tournaments of 20 MCQs on the Incus app. Number 4, we provide you 10,000 PowerPoint slides of notes. Number 6, we provide you 30 full-scale NEET PG grant tests. So all this for a small price of 10,000 rupees. Take every opportunity to call our helpline 9000-868-356 and grab your crash course subscription for the NEET PG preparation with us. So doctor, triple test of the Down syndrome, quadruple test. I had been mentoring the NEET PG and PG medical aspirants past 20 years. Almost 2 lakh medical students I had a God-given opportunity to mentor. So what I understood is there are some topics like triple test, quadruple test. Time and time again, they are frequently asked by the examiner. So you have to be very sure about the answers. Good to see Vipra Vaidya, Kaushika, Pranav, and many more. Keep punching answers, doctor, while the discussion is going on. Before the start of the discussion, please participate in the PowerPoint slideshow quiz tournament so that you are playing along with your friends your answers. Extempore, whatever be the preparation. So you should remember, how do you monitor antenatally, make a diagnosis? There are some markers in the first trimester, some markers in second trimester. In the first trimester, PAP-A, pregnancy associated placental protein A, and free beta HCG. If you use only these two, 65% accuracy. And the fetal marker is nuchal thickness. You can calculate on the ultrasound. If you combine the two, 85%. Then second trimester screening test. Maternal serum alpha fetoprotein, histrion, HCG, triple test 70%. If you add inhibin A also, the sensitivity increases to 76%. If you use both of them, first trimester and second trimester, 94%. So that is the maternal serum screening. Please don't forget. पेपर ले लो, लिख लो, मन में रखो, दिल में रखो, एग्जाम को जाओ, कल के एग्जाम में आने वाला क्वेश्चन है. Kwashiorkor. There's a fatty liver, patchy depigmentation of the hair, and edema. Severely malnourished child. How much should be the caloric supplementation? 175 calories per kg. With regard to the IUGR, what do you like to say about IUGR? So typically in intrauterine growth retardation, the head circumference is 3 centimeters more than the chest circumference. Big head, smaller chest. So that's how you identify IUGR. So in this context, we need to get some favorite funda in pediatrics about the head and the chest circumference. At birth, if you take, head circumference is more than chest circumference by up to 3 centimeters. At around 9 months to 1 year, please don't forget, these are all favorite MCQs. Head circumference is equal to chest circumference. After that, the chest grows more rapidly compared to the brain. So the head circumference is greater than chest circumference by more than 3 centimeters. So what are the 3 conditions you will remember? Preterms, small for date, hydrocephalic infants. In them, the head circumference is more than the chest by 3 centimeters. So till 3 months, 2 centimeters per month, 3 to 1 year, 2 centimeters in 3 months, 1 to 3 years, 1 centimeter in 6 months, 3 to 5 years, 1 centimeter per year. That is how the head circumference growth is what you should remember. So during the first year, there is a 12 centimeter increase in head circumference, whereas 1 to 5th year of age, only 5 centimeter gain occur in the head size is what you need to remember. So the adult head, daddy ka head, bete ko kab utna bada head milta, 5 to 6 years we get the adult head. In hypothermia, what do you see? Bradycardia, metabolic acidosis. So you should know all clinical features of cold injury: cold skin, poor feeding, lethargy, poor cry, bradycardia, arrhythmia, respiratory distress, vasoconstriction, low surfactant, cyanosis, skin mottling, sepsis, coma, death. So that is what hypothermia presents as. A neonate is born to the infected hepatitis B mother. You have to give both passive and active immunization. Passive immunization with immunoglobulin and active immunization with hepatitis B vaccine is what you should remember. Now, doctor, a child presented with headache, giddiness, intermittent claudication with dyspnea. So basically, you should remember, whenever coarctation of aorta is there, there is a narrowing of the aorta. So obviously, the blood flow which is going to the lower limb is decreased, and that leads to development of intermittent claudication in a child. Child is not a smoker. For you to think of any Buerger's or thromboangiitis, obliterans, or any vascular disease of the lower limb. But then why there is an intermittent claudication in the lower limb? Because of a decreased flow due to the coarctation is what you need to remember. A child has headache, giddiness, intermittent claudication, so coarctation. About the coarctation, what is the most common site? Where does the coarctation occur? Coarctation of aorta means aorta में कहीं भी हो सकता, but aorta से subclavian निकलेगा ना. सबक्लेवियन निकलने के बाद जो भी aorta है उसमें coarctation होता है. That is what you need to remember. Now, doctor, what are the most common malignancy in children? Lymphomas, leukemias, most common malignancy in children. Acute lead poisoning in the children. Recently, in Andhra Pradesh, what is that location? Elur, right. So, acute lead poisoning in children, what is the presenting feature? Encephalopathy, seizures, cerebellar ataxia. So, the lead affects 3 major organ systems: central and peripheral nervous system, heme biosynthetic pathway, renal system, and the most important serious side effect is central nervous system. There is a decreased IQ, cognitive effects, seizures, encephalopathy, etc. Especially encephalopathy is more to the lead poisoning in the case of the pediatric population. So what are the classic signs of lead poisoning? Loss of appetite, vomiting, weight loss, constipation, anemia, irritability, learning disability, behavioral problem, hearing loss, delayed growth, drowsiness, clumsiness, etc., etc., and peripheral neuropathy. When do you consider blood lead level considered to be toxic? If it is more than 5 micrograms per deciliter. What are the various posterior cranial fossa tumors? So you should know Metaloblastoma, ependymoma, astrocytoma, they're all posterior cranial fossa tumors. Porencephaly, it is a vascular lesion due to degenerative vessel disease and head injury. So there is a cyst or a cavity filled with CSF developing in the brain. Why does it happen? because of the stroke or infection after birth, the most common type. And typically when the child reaches his or her first birthday, you will identify. There can be delayed growth, spastic hemiplegia, hypotonia, seizures, microcephaly. Anything can be the presenting features. So this is how you can see that this is how you can see a fluid-filled cavity of porencephaly is what you should remember. Now, full term, small for date babies. What is the important complication? Hypoglycemia is very common. So small for gestational age babies can have IUD, birth asphyxia, hypoglycemia, hypocalcemia, hypothermia, infections, polycythemia, etc., etc. Blue patch on eyelids, which disappeared at age 1. Disappeared at age 1. That is a clue. Disappeared at age 1. That makes it salmon patch. So basically, if you look at hemangiomas, they can be central, that is in the bone. There can be capillary hemangiomas, cavernous hemangiomas, or arterial. Strawberry angioma, port wine stain, salmon's notch, they're all capillary. Now, salmon's patch, what is the other name given for salmon's patch, doctor? It is also called nevus simplex. The most common vascular birthmark in the infancy. It is seen in 40% of newborns. Superficially dilated capillaries. If it occurs on the face, you call angel kiss. Nape of the neck, it's called stork bite. It becomes more intense on crying. Most of these will disappear within 1 year. Salmon disappears. So the important clue is it disappeared in 1 year. बोलते ही आप salmon ले लो, salmon ले लो. Strawberry hemangioma. Strawberry 95% disappeared by 10th year of age. Then cavernous, they are usually larger, locally destructive. They are seen in von Hippel-Lindau syndrome is what you need to remember. This kind of erythematous patches present in the forehead, they are called macular stain. So, a lot of times examiner mainly asks you which will disappear, which will not disappear. If it disappears, when will it disappear? So, ये चीजें आपके मुट्ठी में रहे. There is no rocket science to become a topper in entrance exam. There are 427 hours of HD video, doctor, where we have done one of the best discussions. You don't need to read anything else. Do a revision of these 427 hours videos. अगर सीट नहीं आए तो मेरा जिम्मेदारी, ठीक है? So, what should be measured in newborn who presents with hyperbilirubinemia? You have to do both total and direct. Whenever there is a newborn to a mother who has got TB, so what do you want to do? Give BCG, give INH for 6 weeks, plus breastfeeding. That is what you should remember the protocol. Ductus arteriosus. It can lead to the development of a machinery murmur because of its patency. So now, when will constriction of the ductus arteriosus occur, doctor? Within 10 to 15 hours. Whenever the ductus arteriosus is closing, the closure begins at the pulmonary end of the ductus arteriosus. See, ductus arteriosus is connecting you, the pulmonary artery and the aorta. So, along the pulmonary end, the closure begins. Now, Grade 4 vesico-ureteric reflux. There is no dilatation of urinary bladder. How do you want to treat? So you can inject collagen at the ureteric orifice. That is a method. So you should know what is the international classification of VUR, another very high yield topic for entrance. So you have the bladder, doctor, you have the ureter, and there is a kidney, right? So typically vesico-ureteric reflux is because of the seepage of the urine in the backward direction. So grade 1 is reflux, but ureter is not dilated. Grade 2 is reflux into renal pelvis and calyces, which did not show dilatation. Similarly, grade 3, 4, and 5. So first of all, a grading समझने की कोशिश करो. Now, what are the indications of surgery in case of vesico-ureteric reflux? If there are breakthrough UTI, if medical management is failing, not responding, if there is a ureteric obstruction, if there is any refluxing ureter opening into a bladder diverticulum, or if there is a golf hole orifice, they are all the absolute indications for surgery in case of vesico-ureteric reflux, is what you should remember. So how do you treat? There are 3 types of surgery: endoscopic, laparoscopic, open. So Cohen's procedure, Leadbetter, Politenos procedure, they are the open procedures to manage the vesico-ureteric reflux. Charan Raj is asking, sir, developmental milestones. आएंगे पूरा 600 topics, 600 questions we are going to discuss in pediatrics before Saturday. So there's a schedule of our 150-hour program. Please call our helpline and try to get the program schedule of what are the subjects, how are we going to finish them in this daily live evening class. 6-year-old girl presents with recurrent E. coli infection in the urine. Abdomen shows hydroureter, hydronephrosis. Filling defect in bladder. What is your diagnosis, doctor? Ureterocele. It's called cobra head appearance, as all of you know very well. So this is the typical filling defect in the bladder, which is typically seen in case of ureterocele. So this is the intravesicular ureterocele, and this is a ectopic ureterocele. That's what you should remember. In systemic juvenile arthritis, rheumatoid factor can be negative. Brain tumors, remember, brain tumors are the infra or supra. They're infratentorial. So pediatric brain tumors are 15 to 20% of all. Most common tumor in case of children is leukemia. Leukemia ke baad aata hai brain tumor. Overall, supra and infra are in equal frequency. Less than 2 years age group, supratentorial are more common. 4 to 10 years, infratentorial are common. And after 10 years, both of them are equally common. 3-week-old phenylketonuria. You have to restrict the phenylalanine, not completely stop in the diet. Tyrosine becomes an essential amino acid whenever phenylketonuria is there. Serum phenylalanine is increased and urinary phenylpyruvate is elevated. So phenylalanine hota hai essential amino acid. So dietary phenylalanine is not generally used for building proteins, rather it is degraded by the tyrosine pathway. So any phenylalanine hydroxylase deficiency or the cofactor tetrahydrobiopterin deficiency, it leads to accumulation of the phenylalanine. So we have to give a low protein diet. Avoid aspartame, which is an artificial sweetener with phenylalanine. Phenylalanine restricted diet at least several months prior to conception. So these are the few things. Tetrahydrobiopterin supplementation also can help. A neonate has jaundice, clay white colored stools, liver biopsy shows giant cells. What is your diagnosis, doctor? Liver biopsy shows giant cells. That is an important clue for you. It is a case of neonatal hepatitis with extrabiliary atresia. So typically whenever neonatal hepatitis with extrabiliary atresia is there will be markedly irregular size of the hepatocytes. Bile canaliculi typically become reduced. Kupffer cells become swollen. Remarkable giant cells will be seen. And not much of bile duct proliferation. So they are the pathological hallmarks of the neonatal hepatitis. So one of the favorite questions of the examiner, doctor, neonatal hepatitis versus extrahepatic biliary atresia. How do you differentiate? You need to have a clear टेबल को आप दिल लगा के बट्टी मारो, दोस्तों के साथ डिस्कशन करो, फिर भी भूल रहे तो अस्पताल जाओ, पीडियाट्रिक रेसिडेंट से पूछो, भैया मुझे एक नियोनेटल हेपेटाइटिस दिखाओ, नहीं तो मैं घर नहीं जाऊंगा। एक पेशेंट को देख के पेशेंट के सामने खड़े होकर डिस्कशन करे तो खत्म, you will remember. Whichever the way, doesn't matter. So neonatal hepatitis can occur any time during neonatal period. Whereas extrahepatic biliary atresia, it occurs at the end of the first week. Jaundice is moderate to severe in extrahepatic biliary atresia. Stools are clay colored if there is extrahepatic biliary atresia. In both of them, the activity and feeding are normal. Hepatosplenomegaly is more earlier in neonatal hepatitis than extrahepatic biliary atresia. Urinary urobilinogen, stercobilin stools is there in neonatal hepatitis, but absent in EHBA is what you should remember. Serum alkaline phosphatase is more elevated in extrahepatic biliary atresia. SGOT, SGPD are more deranged in neonatal hepatitis. Alpha-fetoprotein elevation is seen in neonatal hepatitis more and not seen in EHBA. Then if you do liver biopsy, giant cell predomination is the feature of neonatal hepatitis, whereas dilatation of the canaliculi is the feature of extrahepatic biliary atresia. If you do cholangiogram, pass a contrast, then if there is an extrahepatic biliary atresia, the block can be visualized. So doctor, A table है ना, तेरा A table को फुटबॉल है ना, ध्यान रखना, कल के एग्जाम में जरूर पूछने वाला क्वेश्चन है. A newborn is having dribbling after feeding, classical story. Respiratory distress, froth around the mouth. What is your diagnosis? Tracheoesophageal fistula. So type A means there is only esophageal atresia, no fistula. Type B, C and D, there is a fistula. They are very common. So the blind ending pouch of esophagus with the lower end of the esophagus communicating with the trachea, this is the most common variety. Obviously, all saliva will enter into pouch and then it keeps dribbling out. That is the presentation. So, tracheoesophageal fistula types, everything you should be sure. 80-year-old boy with upper GI bleeding, splenomegaly, no ascites, no hepatomegaly. Then esophageal varices are there. What is your diagnosis, doctor? Very important clues. N, C, P, F. Non-cirrhotic portal fibrosis. Now अभी NCPF के बारे में 10 पंक्तियों में बात करेंगे भैया. Splenoportal axis hepatic veins, if you look, they will be patent. There will be massive splenomegaly. There's a portal hypertension. Portal hypertension. Varices, collaterals, they are there. But non-cirrhotic portal fibrosis, इसलिए normal liver function. That is the clue in the clinical minute. Then hepatic vein, portal vein, gradient, if you look, it is normal. No evidence of cirrhosis. No signs of chronic liver disease. That defines the NCPF, is what you should remember. So, non-cirrhotic portal fibrosis and portal hypertension. What are the differences? NCPF is equal in boys and girls. The mean age of presentation is 30 years, NCPF. Autoimmune factors are not the feature of NCPF. Parenchymal nodules, bile duct proliferation, they are the features of NCPF. Hepatic vein, portal vein, wedge pressure is higher in IPH. Hematemesis is more often seen in NCPF. ये differences डिब्बा also आपके दिल में बैठ जाना. Favorite question. Radiologically, if you look at NCPF, there will be no evidence at all of cirrhosis. Subcapsular parenchyma will show atrophy. And there is a peripheral pruning of the portal vein. That's called withered tree appearance. Withered tree appearance is the feature of NCPF. And there's a splenomegaly, gamma antibodies, they are the features of NCPF. So please don't forget. So extrahepatic portal vein obstruction versus NCPF versus cirrhosis. ये जो टेबल है ना डॉक्टर, फुटबॉल ले लो एंड दिल में लगाओ, डेफिनेटली आने वाला क्वेश्चन है. फोटो ले लिया, बढ़िया. एक दो मर्तबे दोस्तों के साथ बैठ के इसको you have to do the churning. 8-year-old boy with upper GI bleeding, splenomegaly, no signs of ascites or hepatomegaly, and esophageal varices, classical of NCPF. 5-year-old boy with nephrotic syndrome, commonly is minimal change disease. There's a reason light microscopy, there are no findings at all. So what is the most common cause of urinary obstruction in a male infant? Posterior urethral valves. A 5-year-old child, calculus size is 2 centimeters in the upper ureter. He has hematuria, no obstruction of urinary tract. How do you want to treat? This candidate is a good candidate for extracorporeal shockwave lithotripsy. So doctor, you should be very sure how do you manage the ureter based on the size. Ureteral stone. Small stones. Small होता है less than 7 mm. Large होता है more than 7 mm. 7 mm होता है criteria. But less than 7 millimeters, 2 to 4 weeks give time for it to pass. Or you can, if it is in the lower ureter, ureteroscopically बाहर खींच सकते. But if it is mid or upper ureter, then you have to do shockwave lithotripsy. If it is a large ureteric stone, then you need to do a ureteroscopic stone fragmentation, open surgery, ESWL, all of them are options. So in this given case, since it is 2 centimeters and it is typical look in the upper ureter बोलते ही आप क्या याद रखेगा? Typically ESWL. That is the point you need to remember. So doctor, that brings us to the end of the today's session. I want to invite all of you to join the crash course every day evening, 6 to 7:30 p.m. You have your classmate, roommate, benchmate, tablemate, reading roommate, Dr. Murali Bharadwaz, to study along with you, live online class. Before the class, exactly at 6 o'clock, we are having a 50-question quiz show, PowerPoint slideshow. Keep punching your answers. Every 12 seconds, a slide is moving. That brings that spirit to prepare. Then there are 427 hours of video lecture. 1,500 lectures are available, which is available in the online MBBS. So please take every opportunity to join for the NEET PG crash course. Good night and have a great time. Thank you.